Welcome to the Society for Equity and Neuroscience State of the Science webinars, also called the SEQUINS Sequinars. The organization was founded in 2024 and aims to enhance brain health around the world by improving equitable nervous system care and outcomes through research. These State of the Science sequinars were designed to highlight recent advances in equity neuroscience research shared by our scientific leaders and eminent equity neuroscientists. And we have the pleasure of Dr. Michelle Nelson joining us today as our featured speaker for the State of the Science. So Dr. Michelle Nelson is a senior investigator at the Bruyère Health Research Institute, and I did not pronounce that with a French accent, and I apologize. And associate professor at the University of Toronto. She leads the Care in Common Living Lab, which is focused on implementation science and integrated care. She also serves as the vice president of the World Stroke Organization and is joint editor-in-chief of the International Journal of Integrated Care. As a principal investigator, accomplished scientist, she has over $15 million in funded research and has made just incredible advances in health equity through collaborative partnerships and between healthcare systems and community organizations in particular. It is wonderful to have you here, Dr. Nelson, and thank you for sharing with us.
Oh, it was such a pleasure to be invited. So I'm going to pull up my slides and then I'll tell you a little bit about me. So in the true spirit of a sociologist, I'll situate myself in the work. So I'm going to pull up my slides. If someone could just give me a thumbs up if you can see them now.
Thanks, Michelle. You're good to go.
Perfect. Thank you. So, thank you for the introduction, Janet. As said, my name is Michelle. So I thought it made sense if we're going to talk about trust as an equity practice and the relational considerations of trust, that you know a little bit about me so that you can situate me in relation to the work. So I am a sociologist first and foremost. I'm a recreation therapist and have worked in neuro rehab for quite a while. And then my PhD and subsequent work was really around person-centered healthcare and how we deploy interventions to support the alignment between clinical practice and the whole person who shows up in our health settings and services. If you have read any of my work or heard me talk, you will know that my most recent interest, maybe for the last decade or so, has really been around integrated care and the idea of intersectoral partnerships. So how do we support organizations and systems and services and sectors to partner in really meaningful ways to allow for more seamless continuity of care and patient journey? And integral to that, though, is this idea of relationships. So relationships between the settings and sectors, relationship between the people who work in those services, and then obviously the relationships between the individuals who are traversing the pathway and the systems. So that's how I came to be really fascinated by the idea of trust and trustworthiness. I knew my own clinical background. I felt like I was a trusted clinician, but I knew I was also an agent of the organizations that I was working in and wanted to be sure that we, as a set of clinicians and individuals, were actually working in a place that was aligned, not just to our personal values, but the work we did represented organizational values and we walked the walk. So that's a little bit about how I've come to this. And so what am I going to do today? Well, we're going to talk about trust. What do we mean by trust? What do we mean by trust in healthcare? What do we know about trust in healthcare? What does trust as equity infrastructure actually mean? And how am I conceptualizing that? We'll talk about what this looks like when we talk, in something grounded in real life. So I'll tell you a little bit about my own work in stroke rehab and practice. And then we're going to have a conversation about how to systematize trust and equity as infrastructure. So really, this is where I always start with this idea of, we've been talking about health inequities, we've been talking about the systemic, avoidable, and unfair differences in health that can be observed between people populations. A great article, Campbell et al. And then there's this line that says, we have been trying to tackle health inequities um, through scientific work, national, international policy for decades. And as soon as I see we have been trying to do something for decades and we've not made meaningful, substantive movement as a system, it makes me think, the classic phrase, we can't solve problems using the same thinking that we use to create them. And what would happen if we tried to explore this topic from a different lens? Now, I'm an implementation scientist, so I really care about how do we move this in from ad hoc practice or individually dependent into something that is systematizable, consistent, and scalable. So we're going to talk about that because I think this idea about flipping it on its head is important. I did the work to determine what is the scope of the literature on this. I'm saying I did the work somewhat facetiously. You can see I Google Scholar searched trust, equity, and healthcare, and you can see that I received 983,000 possible results. So we're not talking about a body of work that hasn't been substantively discussed. So when I'm now saying, okay, how do we move from 983, almost a million articles? How do we move this in a way that we know how to move in practice at an individual and at an organizational level? So this is really where I'm trying to situate this work. So the great article, Taylor et al., they did a review of 50 years of trust research in healthcare. They found 725 articles that they synthesized, and they came down to these two major points. We've got conceptual murkiness. We really haven't agreed on what trust means. We'll talk about that through the course of the discussion. And we have limited observability. So many of you likely, when you think about trust in relation to your work or in relation to your life, we often think about it something that we like about somebody or we believe about somebody, but we couldn't actually put proof to that statement. So what do we mean by any of these terms? And we know that trust and trustworthiness, mistrust and distrust are often used synonymously. For the purposes of our conversation, I'm going to do my very best to delineate trust as the individual reliance on or confidence in the dependability of someone. And trustworthiness is the characteristics of the individual and the organization that they are competent, have integrity and capability. So I always think about I might trust someone and I have to decide if they are trustworthy. So just because we trust, we can, so yeah, I'm sure you've heard the saying, fool me once, shame on you, fool me twice, shame on me. And that's that idea about trust and trustworthiness. And then I think we see a lot of overlap in the mistrust, distrust literature. And I would distinguish that mistrust is learned wariness from historical harm, learned wariness, skepticism that is actually based on considerations in the environment. Distrust is somebody has done something that has given me the ability to make an evidence-informed judgment of somebody's untrustworthiness. So these terms are often used synonymously, but I think we really need to be careful and really start to help resolve the conceptual murkiness. So what do we mean by trust? If you think about your own life and who you trust, what is it about them that makes you trust them? Usually it comes down to three factors. Some people have authenticity. They act in ways that are consistent with what they say. Logic, you can observe that they are actually acting in a reasoned and reasonable way. And empathy, they care about me as a human being. I really like the quote by Anne Morris and Francis Frey. And if you haven't listened to their Finding Mastery podcast, great resource. They talk and they say that trust consists of authenticity, logic, empathy, all three simultaneously. When you have all three of those cooking, you earn trust. When you aren't earning trust, you can always trace it back to one of those dimensions, authenticity, logic, or empathy. But the prescription for overcoming it and rebuilding for each of those dimensions are different. So we need to have careful diagnosis. I'm just going to point out the number of times we talk about measurement, identification, being able to have conceptual clarity around these terms. And so this quote, I think really, when we look at it, it reflects both our work and the way we live in our life. So I went to some of the literature and I tried to determine what do these characteristics and what does characteristics of trust look like for people with lived experience. And so for those of you that work clinically, um, these may resonate. For those of you that don't work clinically, you may think about people that you trust and how they relate to the way you interact with them. Competence. You expect people to have the knowledge and skills required for the activity. So the actual ability to assess competence, though, is very challenging for patients and families. They have to assume competence. And if you have to assume competence in a system that you have rightful mistrust in, then how does that actually relate? I trust you to approach my care with humility, recognizing that there are aspects of me that may require collaboration and openness. So that might be collaboration with other health disciplines. It may be collaboration with me because I and my family know things about our health, our life situation that you need to be able to make good treatment recommendations. The idea of integrity, the idea of reliability. So we think about, I trust you to be there when I need you. I trust you to do what you say you're going to do. I trust you to follow through on your commitment. And this is one that, as a clinician myself, I struggled with because we would talk about what should happen or what was likely to happen. And you wanted to be careful that you didn't set up unrealistic expectations of the system that you can't control within your clinical setting. And it was this tension around trying to fulfill my commitment to a patient and their family, but knowing that many of the things that we were talking about in a stroke system of care may actually be beyond our control or beyond our influence. And then integrity, I think we know when people act with integrity, it's that classic, they do what they say they're going to do, they walk the talk. They put their money where their mouth is. All of those euphemisms about how we know somebody is acting with integrity. And one of the things that we are quite good at as clinicians is being honest with people, even when the news is hard to hear. I think we need to be careful sometimes that we don't use that and actually quash hope. But I think we have developed a good ability to communicate in ways that even if the message is hard. So when we talk about trust in healthcare, we've all been in healthcare situations as patients. And we know that that experience can be profoundly vulnerable, even if you're relatively well. And so thinking about having to disclose information, ask questions, go into unfamiliar environments, put yourself in bodily vulnerability situations. And I think we really need to flip the script to talk about when people or communities distrust, that's not a personal deficit, that's a system failure. And that interventions that we deploy to try to increase people's trust without making the system trustworthy is really asking people to be vulnerable yet again in institutions that they know have harmed them or people they care about. That isn't trust building. And I love this idea. I heard it many years ago, but a philosopher said, it's wrong to seek to win trust when you know yourself to be undeserving. And the importance of reflexivity in our practice, reflexivity in our own self and the way we show up in the world, being values driven, and then being able to say, how does that influence the way I work? And how does that align to the organization I serve in? It wasn't related to equity, but I had a colleague who the organization had made a strategic decision, an organization she worked in had made a strategic decision that profoundly misaligned with her personal values. And I asked her, how is she going to manage that? And she said, I can't work in an organization that believes this is the path forward. And so I will find a new place to work that aligns with my personal values. And I thought that was at the time, thought it was so brave. She wasn't a clinician. She worked in a totally different field. And I thought, what would happen, because we know that there are many clinicians who are working in organizations with value misalignment, or they're doing the best they can to promote and bolster the organizational values through their relationships. So I just want you to think about some of these things, because when we talk about relationships and relational aspects of trust, we're going to revisit this idea about the individual as the agent of the organization. So what do I mean when I say equity as a trust as an equity infrastructure? And I really think when we look at what we call health system infrastructure, we talk about the fundamental frameworks and resources that are required to drive effective health service and programs. So it's easy to think about technology, it's easy to think about materials, it's easy to think about the buildings and as infrastructure. I would like to see what would happen if we considered trust as infrastructure. So this, I think, would allow us to make the invisible visible. So moving from what we know at an interpersonal level to be trust, and how do we create it as an architectural or structural element of our system? Infrastructure matters because the using infrastructure, it really matters because it will allow us to assess and reveal, the factors or the system considerations that create, perpetuate, maintain an equitable distribution. So we would then be able to map it and assess it. And then, looking at what would we actually be mapping? Well, we're talking about information systems, accountability metrics, resource allocation processes. And so when we start thinking about infrastructure and we attend to it the same way that we do for technology, equipment, human resources, it allows us to take a different lens on the work. I also think this is a great place where we can start thinking about other ways that we have shifted infrastructure. So looking at effectiveness and efficiency models, looking at return on investment considerations. Those ideas we don't tend to think that way when we talk about trust. And I will come back to that when we talk about disciplinary differences. So if we're talking about trust as equity infrastructure, then we have to think about the relational, systemic, and bidirectionality of trust. So the relational, relatively easy to understand. Systemic, it's that we as clinicians or as individuals within an organization are often seen as an agent of, and so our actions allow people to make judgment about the whole. So we are part of the whole, we are our whole in ourselves, but we have to also think about when we may be part of the ecosystem that people are thinking about trustworthiness of the organization. So a systems perspective will allow us to see the interdependencies between individuals, systems, settings, and then the broader health system as a whole. I love the idea of trust banking. And if you don't know who Jay Shetty is, he has written a few books. He's very, very popular. He's not a clinician, he's not a health system leader. He's an individual who lived in a monastery, left the monastery, and now talks about trust, relationships, love. And in one of his books, he talks about this idea of trust banking, and that trust tokens are what we create in each individual moment, but then you create a trust bank where positive behaviors add and negative interactions deduct from it. And then when you take that into what we know in other fields, in the psychology field and child development field, they talk about the number of positive interactions that are required to overcome a negative. And when we talk about in human resource management, we talk about feedback. We talk about the number of positive pieces of feedback that are required to overcome a negative. And even in high trust environments, we're talking a 5-to-1 or 8-to-1 ratio. So if you in a trusting environment need to do 5 positives to negate every negative, what is the ratio when you have systemic mistrust? I don't have the answer to that, but I think it's an important point for us to think about the salience of negative, the particular salience of negative when it meets the expectation for negative, rightful mistrust, and how is it fair or reasonable that any individual clinician can possibly accumulate enough positives to overcome a systemic negative? So I will leave you with that thought. Um, so let's talk about rehab. And I know I saw in the list that there are some rehab clinicians. So this is my particular space. Um, rehab is an interesting context to talk about trust. We know that rehabilitation is usually built upon extended hospital stays. Usually you don't see a rehab hospital unless you need rehab or have been around somebody who has gone to a physical rehab program. Physical rehab programs are extended, so you usually have a long time away from work. Your families need to be away from work. Usually there's equipment needs, there may be communication challenges, there may be indications about what home and vehicle modifications may be required prior to discharge, and all of this while people are trying to navigate fragmented health systems. Then we know, we've talked about the vulnerability. And I think I really like to stress that rehabilitation is an incredibly intimate clinical process. And I don't mean physically intimate only. Rehab clinicians are often privy to people's most private spaces, whether it be their home, whether it be their family dynamics, whether it be their financial status. We know that it requires physical touch in many cases, but it also is grounded in the idea of supporting emotional recovery. And so that link between vulnerability and intimacy in rehab for prolonged periods of time is an opportunity where we start to see family dynamics, witness power imbalances, and the need for supports and services that sit outside our traditional clinical services. This doesn't even take into account the profound functional, cognitive, physical, functional impact of stroke. This is actually the clinical. So if you can imagine you're managing all of this while also managing the impact of stroke, it really creates an opportunity to really critically appraise the role, the value of trust between individuals and clinicians, but also the trustworthiness of the clinical program as a whole. So I'm giving you a list. Each one of these are its own substantive body of literature. Again, a million articles on trust, equity, and healthcare. So when we go down the list, I'm going to highlight a couple of examples that I think are particularly interesting. And what's in the system that actually breaks trust? We know that there are biases and stigma considerations to referral to rehab. Most recently in the article, the citation is at the bottom, an article noted that people who were referred to rehab because they were survivors of violence, if had decreased access to rehab, and that became even more so if they were a member of a systemically marginalized population. So when we look at who gets into rehab, we already have a trust-breaking access to rehab. When we think about what constitutes independence and what is the point of coming to rehab, independence versus interdependence, the idea about a Western world approach to rehabilitation and the aim of functional recovery and independence at home may not align to the individual's perceptions around interdependence, collectivity, and what is valued for them and their family. We talk about the mismatch of interventions, rehab interventions, evidence-based practice, and the populations we see. So I did a study a few years ago looking at who got into stroke rehab trials, looking at comorbidity status, and we determined that, that if you were older, had had a stroke previously, had some cognitive impairment, you were unlikely to get into a rehab trial. We then took that and we looked to see how that would actually match the people that we saw on the clinical unit. And we looked at a year of consecutive admissions and discharges and determined that, in fact, most of the people who were on our clinical unit likely wouldn't have got into a trial. And that was looking at just a few characteristics. We know that there are biases in our sampling for trials. We know that there's much more work to do to ensure that we are reflecting the reality of the clinical population. There's some interesting work about adherence, non-adherence. There's an article that I've cited at the bottom that really notes that when it comes down to perceptions of non-adherence, I hate the term non-adherence, first of all, but the literature still uses it. I would much more prefer, we talked about concordance, but concordance is actually a relationship and an alignment based on trust. So non-adherence. In white populations, non-adherence was identified as likely being due to circumstances. For non-white populations, it was often perceived to be as a result of personal failing. So we've got a bias there. Informational asymmetries. I've got a colleague, Hardeep Singh, at the University of Toronto that does a lot of work around culturally relevant and tailored programming. We know that we need to be providing information in ways that address people's first language, communication patterns and preferences. We know that we need to be looking at how to tailor so that we've got widespread uptake. Jennifer Beecham, you may know her. She did the work around Rapido and making sure that symptom awareness approaches were translated in a meaningful way to Spanish. I always encourage, though, that even in addressing culturally relevant or tailored programming, a master's student, Miranda Wu, noted that even in culture sharing groups, they themselves would identify that you can't have a panacea of culturally relevant and tailored, because even within there are variations that require person-centeredness. And then this most recent article, it literally came out last month, and the author talks about medical gaslighting and how we can manage patient clinician mistrust in healthcare, and it just came out. So it's a great read for you. Okay, health promoting. I'm going to talk about therapeutic alliance a little bit more, but we know that for trust promoting, if people are transparent, accountable, and vulnerable as clinicians, that promotes trust. What does that look like, though? How do we try to maintain the idea of our system functioning and trying to promote the idea of trustworthiness, but also be vulnerable and say, this is how the system actually works. This is what's likely to happen when you go home. We're going to do our best, but I can't promise. And that feels uncomfortable as a clinician to say, here's what we hope will happen. However, there is a chance that that may not go to plan. Shared decision making, huge body of literature. When we talk to people around equity, it really is the move from what matters in our program to what matters to you and how do we support you to get there. As a note, I've had a lot of conversations over the years about the idea of unrealistic patient goals, unrealistic patient expectations of rehab. And when people stress what's important to them, I think our job as clinicians is to walk it back, break that into reasonable steps, and say, how do we move toward achieving what's important to you, rather than saying, dancing at your daughter's wedding is unrealistic in the next 3 months. If that's a goal, we need to be thinking about how we move it. I think there's an opportunity for us to call our pre-licensure practice and education forward and say, how do we do critical theory-driven education? What does it look like if we're working in critical theory-informed ways? How do we bake this into the way that we work rather than asking people to adapt in practice? This is being done in many cases, but I think there's an opportunity for us to systematize it. And then, of course, person-centered tailored interventions, which I say it as, of course, but in fact, we know that even if an intervention is person-centered, the reporting of it doesn't say how it was created to be person-centered, so we can't learn from what other people have done so that we can borrow that practice. So I think we had written a paper, actually Janet and I and colleagues said that, we need to be thinking about what matters to people and how do you report it in a way that allows for others to see that. I want to talk about the therapeutic alliance, though, because I think a red thread through this talk is this idea that individual relationships will actually overcome the deficit of a system. And so there's lots and lots of literature on the importance of therapeutic alliance and what that means in terms of ability to have improvements in physical and emotional conditions, to feel supported, be seen for who they are. We know there are asymmetries in this, though, that not everybody has access to a strong therapeutic alliance. So, what does it mean to be in a therapeutic alliance? Collaborative, goal-oriented care, shared decision making, effective bond between patient and practitioner. So you can see that these are tactical, but they are also grounded in relationship. So it requires a therapist to show up in a particular way and to create the conditions for an alliance. That to me, I think it feels like an unfair responsibility to put on a clinician, if particularly, in fact, if we're going to look at things like non-adherence, sort of dissatisfaction with care or with the system. And so I really want to problematize this idea about the therapeutic alliance. So for those of you that work clinically, the idea about power imbalances between the individual, the patient, the family, and the clinician. We know that many times the decisions about system or care provision is not related to what the individual clinician believes should happen, that it's actually dictated by external, whether it be organizational, whether it be within the broader stroke system of care. And so if you're a proxy, if you're an agent of, how do you create an alliance that's actually you on behalf of a broader system? And how do you create that alliance that it truly has equitable power? We've talked about this idea about whose goals matter, and I've sat in endless number of discharge rounds where what matters to the person is important and acknowledged, and we have to balance the length of stay, targets, the throughput of the clinical unit. We know we have a decreasing system availability and increasing demand on rehabilitation. And so are all these factors come into goal setting. And when somebody's individual goals conflict with the broader therapy goal of functional improvement, discharge home, how do we actually manage that? And I don't know how many of you have had this situation where you're trying to do two things at once. You're trying to support the individual to achieve their goals, and you're trying to work within the constraints of the system. Number three is really the one where I get quite passionate. And I'm going to go back to my own doctoral work because I looked at the experience of being a patient in stroke rehab. And many of the people that I followed would say that they really had a great relationship with their therapists. Not as good as their nurses, interestingly, but they had good relationships with their therapists. And as we explored that concept more and more with them, it became apparent that the basis of that good relationship was actually on doing as I'm told. They like me because I do my homework. Um, I will do anything I need to do so that I'm seen as a good patient because I want to be discharged and I want to be discharged soon. And so that's not a therapeutic alliance. That's actually conceding to the requirements of the system, and the rapport is people we indicate it as an alliance, but in fact, really what it was compliance. And so I think it's really important for us to think about what's really happening in a relationship, and simply because it looks good or feels good doesn't mean that it's actually an alliance. So I feel like I just need to hammer this point home that really we're talking about trust deficits, and a therapeutic alliance really requires trust. Individual relationships cannot overcome systemic betrayals. And if we rely on individual relationships, we run the risk of not attending to the historical trauma and ongoing discrimination. And an individual cannot be the only one acting in a way that is trusted or trustworthy. So I just feel like I just needed to double down on that for you. So what do we mean by theory? What is trustworthiness? And this work just came out, actually, the idea about trustworthy systems and what is the theory of change to inform it. So you can see it came out in 2024. I love the title, Being a Trustworthy Professional in an Untrusting World. And the idea that we really look at three dimensions, and that the system level approach is important. You can't build a system if you don't acknowledge and redress, but you can't actually stop at acknowledging and redressing and closing, because that's not walking the walk. So if you open the door to acknowledge breaches of trust, you need to go through the subsequent steps to actually close it, address those inequities, and then build systems that strengthen trust for the future. So this was when I thought the idea of trustworthiness is so important and interesting for us to talk about. Um, it also then made me go back to the Taylor article, where of the 725 articles they included, only 127 of which actually looked at trust in the healthcare system itself. So we've got a systemic mismatch between what we've examined and where we need to go. Building on this work, Bruyère et al. Said, okay, well, what does this look like if we move it into practice? And I really appreciate operational considerations. So they identified 4 domains that would really move equitable access into practice. But in my mind, these are actually foundational to trustworthiness. So if you look at leadership, prioritization, and accountability, it's embedded into the mission, vision, culture. I think we do that. We see a lot of messaging around equity, inclusivity, diversity in our organizational vision mission statements. But what I really liked was the idea about measuring progress against those and then putting them on performance scorecards and potentially executive compensation. If you're going to do that, though, you need a strategy. So you can see how it starts to cascade down. If you're going to have a strategy where you develop an organization-wide approach and you build in these models, you need to be able to measure it. And if you need to be able to measure it, you need to have indicators of, and the idea that you're actually able to report it back. So again, this really interesting idea about quality improvement model and thinking that can lend itself to trust as an equitable equity infrastructure. And then it warmed my heart, because this goes back to my own interest, that in their domains, they talk about creating partnerships and the idea of building frameworks for organizations around shared goals. And I love that they call out innovation, disruptive partnerships, and moving beyond the health sector. If you've heard me talk about this before, you'll know that I strongly encourage for us to think about how health systems and other partners work to the top of their scope and role, and don't encroach where they don't need to be, so that we truly, in that systems theory way, we actually get greater than the sum of the parts by leveraging the collective expertise. And I really appreciated that it showed up here. So, but we come back to, if we wanted to build it into measurement strategies and we want to build it into quality improvement plans and thinking about how we report on it, we have a measurement problem. So after 50 years, you would think that we would have had a measurement strategy. However, we haven't quite got this figured out yet. If you look at the trust scales, there's 45 plus trust scales that are identified, which really conveys that we haven't quite figured out what to measure or what is the most important thing to measure or how to measure it. We talk about trust as a multidimensional characteristic, communication, honesty, confidence, competence, integrity, etc. But when we look at the tools, they are often unidimensional. So we have a mismatch between how we measure and what's important. I really appreciated the note that while there were fewer mistrust scales, they were actually more fewer available, but more of them had been validated. And when I dug into that, it really lends itself to the idea that those instruments likely had been created or were created for specific populations who had rightful mistrust of systems. So they were more easily validated. And then, of course, this idea about we've not taken it to a system level. There are some case studies that are underway in various New York health systems, and I'm sure that those will be reported in the coming years. But at this point, we don't have clear consensus on what system level trust looks like. Um, so going back, I really think it's interesting when we get to the limited observability. So when you really think about what we're trying to measure in trust, we're trying to measure the likelihood of a future event. But in fact, we know that people have to make a judgment about trustworthiness, and they may be making it in the absence of complete information, or they may be making it on the basis of historical data. I'm sure you've heard the saying, the best predictor of future behavior is past behavior. And if that's the case, when you start trying to predict trustworthiness, it really poses a challenge around being able to align measurement and outcome. I think it's really interesting, and because I come at most things from a sociology and discipline first, this idea about trust defined inconsistently. And I'm not sure the disciplinary background of all the audience, but if you're coming at this from a health economist perspective, you're going to have a very different lens on trust and how to measure it and what it means. If you're coming from psychology, you have a very different sense. If you're coming from a rehab discipline, you may have a different sense. And so I find this idea of murkiness and disciplinary perspective really interesting, because what I think could be happening is we can be talking essentially about the elephant. I think it's this, I think it's a tree, I think it's a rope, I think in fact, and we're passing each other as we talk about it because we are measuring different things and all talking about it like it's trust and trustworthiness. So I think there's a really important role for us to be really clear on what it is that we're measuring. And I think if we can't articulate it, operationalize it, and measure it, it's going to be very difficult for us to systematize it, assess it systematically, and then hold individuals and organizations accountable. So the measurement challenge is a profound one for us. I can't do a talk on trust and trustworthiness without talking about the concept of borrowing trust. I made the comment earlier that nurses are consistently trusted more than physicians. In my study, the nurses were trusted more than the therapists, even though the therapists were the person that they saw as being their goal-oriented clinical team member. And when you looked at it, there's a lot of literature around how physicians, specifically physicians, can borrow trust from nurses to deploy therapeutic gain. And I think that's really interesting about where we can be learning from each other. So who has a trusting relationship? How is that formed? How is that deployed? And is there a way to borrow trust and actually use that to support clinical practice? I think we really need to be careful, though, that often that trust is embedded within traditional power hierarchies and asymmetries in power, and that if we borrow without acknowledging that, it can be problematic. My So I have said many times, I just published a paper that talked about the unique position of community organizations in supporting equity. And we know that we want to see partnerships. It was in the 4 domains. We've seen it over and over. This idea that we want to create relationships. My caution has always been that although community leaders may be able to see individuals, find individuals, support individuals because they're members of their community, we can't engage in partnerships without adequate funding and power sharing. If we do without those structures, it's an extractive practice. We're using individuals and organizations to deploy or to reach a group. We run the risk of burdening under-resourced organizations and individuals to fill the gaps of untrustworthy systems. And so we need to be thinking about how we show up. So to my earlier quote, it is wrong to seek trust if you know yourself to be untrustworthy. This idea about how do we come into that with the spirit of collective gain and the idea that we're doing this to support health of a population. And I really like this idea. You can't borrow trust and as a way to get out of being untrustworthy. You have to build the infrastructure to be trustworthy. Um, and so that's one that I just keep coming back to, that authentic, meaningful partnerships and collaboration. So I'm going to leave it at this, the call to action. As you've heard, we've spent 50 years measuring trust. We've talked about it as a relationship. We've talked about it as a psychological state. We've talked about it as an attitude that underpins access to or utilization. But what if we shifted that and we actually spent the next decade or two building trustworthiness as a system architecture? So then our question really wouldn't be, how do we know if patients trust us? The question really would move to, how do we know we're building a system that's trustworthy? And then how do we share that so we can support equity at scale? Thank you. Here's my contact information, LinkedIn and email. I would love to continue the conversation if people would like to talk about trust and trustworthiness in healthcare. Janet or Bruce, back to you.